So I'm going to talk about multidisciplinary management options for patients with spine tumors. And I think if there's one key slide, this is the slide, which is really there's a lot of difference of opinions, different of management schemes, different algorithms for patients with spine tumors. And I draw my key decision making from our dedicated spine team, and you're going to meet some of them today. But in essence, dedicated spine team is essential for optimal patient management. It's the spine surgeons, the medical oncologists, the radiation oncologists, radiology when it comes to image interpretation, and since a lot of these are multidisciplinary, other surgical things. Building these programs, a lot of you guys are going to go and do spine tumors, but ultimately, if you end up, we have several of the faculty who are much more younger but finding themselves in positioning of building spine tumor programs. And it's very, very important to make sure that, as some of you will go out there to run, build, manage patients with tumors, to be able to develop a team that you can work with, a multidisciplinary team where each patient is really being evaluated and a multidisciplinary decision is being made. It's super critical for the management of spine tumor patients, because ultimately just to make your own decision in isolation is not optimal for this patient population, because you can do a little and you can do a lot, as you know, in a lot of these patients. So what to do or what not to do is always in a forefront of what patients with spine tumor is about. And I'm going to go with a couple of cases because I think we can always talk big, but I think as you go through a lot of cases, you start getting a feel maybe of some of the ways I manage these patients with my own colleagues. So, for example, we have a 23-year-old coming to the emergency room, developed some back pain, complaining of some mild weakness in her legs, and on exam, mild weakness in the hips, 4 out of 5 strengths, as a sensory level, and here's the MRI. And she just showed up to the emergency room, and you can see a pathologic fracture at T9. There's severe cord compression, no history of cancer, very mild weakness in the hips, but otherwise, there's no severe weakness, there's no bowel bladder issue, just a bad-looking MRI. Here is the contrast enhanced. There is tumor in the canal, severely compressing the spinal cord. There's maybe tumor, maybe not. Again, no cancer diagnosis. And here's a few more images. Here is the CAT scan. There's mild pathologic fracture there. There's what appears to be some sort of a lytic process in the vertebrae. And the question really is what to do. And you can see that the surgeon who got called to the emergency room decided to do a laminectomy here. And you can see the CT scan post-laminectomy. There was no instrumentation that has been placed here, just a laminectomy for decompressing of the spinal cord. And you can see the MRI after the decompression right here. And you can see that the cord is decompressed, but there's still a lot of stuff around the vertebral body and in the canal. And this is end up to be lymphoma. So the specimen was sent, and this turns out to be a lymphoma. If you take the same case, but the presentation is with paraparesis of the lower extremities, with significant weakness in the leg, then the question is whether you would go ahead and do what this surgeon did, which is a laminectomy. Where is it the point where you're getting pushed toward doing surgery versus not doing surgery? So my goal here is to show you that if maybe you would have known that this is a lymphoma, you would have considered not operating on this, considering that lymphoma is a very treatable, non-surgical disease. It's in many ways a medical entity disease that can respond very well to non-surgical options. And when I talk to surgeons and I show them this case, where there is severe cord compression, there's mild weakness in the leg, I actually find a lot of questions and maybe even resistance to say, are you actually proposing not to do surgery on a patient who has some hip weakness, potentially can deteriorate, and not operating in a favor of waiting and figuring out what this is? And I listed a couple of things that I get pushback on. Udi, I listened to your talk. I tried it with one patient. It's more work because you have to do the workup, you have to get a biopsy, you have to do a lot of non-surgical work. It was less fun. I got paid less. You don't operate. You're actually not operating on a patient like this. I am a surgeon. I'm supposed to operate on stuff like this. I can get into legal problems by quote sitting on a patient who has severe cord compression and not operating on this patient, waiting for the biopsy, waiting for the diagnosis. I'm not willing to sit on a patient like this. And so from now on, I'm going to operate on them all. I'm not going to take that chance. But if you look at all these lists of reasons, there's no reference to the patient here. This is all other stuff. Here's another case, a 65-year-old with bilateral cervical radiculopathy, neurologically intact, severe cord compression, intradural lesion, looks like a meningioma. There is a dural tail over here. This patient ended up with a PET scan that shows some activity here, and with a very small dose of radiation, this tumor has shrunk completely without any surgical intervention. So I'm showing you another case here where there is no role for surgical intervention, but maybe there's some chance that you have to take to figure out what is the appropriate route here. Here is a 51-year-old person who does come in with neurological weakness, 1 week progressive foot weakness, bowel bladder dysfunction. You can see a very large mass in the sacrum that explained these neurological deficits, filling up the sacral canal. This patient, without a diagnosis, was taken to surgery, had a laminectomy, intralesional debulking, and the post-op diagnosis was considering chondrosarcoma, which is a primary bone tumor, and considering the diagnosis followed by radiosurgery. Symptoms resolved for a year, only to come back to see this big bulb thing sticking out of this patient's back. He thought it was a screw. MRI showed severe tumor recurrence in this previous operated site, and that thing that he thought was a screw was actually tumor getting ready to burst through the back of his skin. The rods were also broken. There were no fusion. This patient needed an en bloc resection, and in a sense got relief for 1 year, only for all these symptoms to return. And so I ended up taking him to surgery, removing this lesion, but it required a big flap, not an optimal situation. Here is another patient with breast cancer, 2 pathologic fracture in the cervical spine. This patient, instead of offered surgical intervention on this case, ended up getting radiation. The radiation led to further collapse of the vertebral body, further cord compression, as you can see right here. Look at the pathologic fracture here. There's no cervical deformity, meaningful cervical deformity here compared to what's happening here, where after the radiation, the 2 vertebrae collapse on top of each other. And this patient ultimately ended up going through extensive surgery. You can see here with cage reconstruction and restoration of alignment, and something that looks like this. Here's a patient who had melanoma and had a vertebroplasty done for this, for a pathologic fracture. There was absence of the vertebral body posterior wall. And what you saw here is that with these cases like this, it's very easily finding yourself in a situation where that cement leak into the canal. The back wall was missing. You can see right here this appearance of maybe badly chosen vertebroplasties where cement leaks into the canal, and ultimately they end up getting this type of surgery where you have to get in, get the cement out, reconstruct the vertebral body. And that's what I did here with anterior reconstruction with a cage. This particular melanoma case ended up getting an anterior vertebrectomy with reconstructions. So I'm showing you some of these cases because I call it a triple W, as a lot of you guys probably have heard me already talking about the wrong operation on the wrong patient by the wrong surgeons. And I want to take it even further for this most recent case where I had a 50-year-old with an unresected giant cell tumor with very minimal movement in the lower extremities, loss of bowel bladder. Look at what you see here with a massive pelvic tumor that's non-resectable. And this patient's main issue was pain control. And if you look at this tumor, the pelvic bones were involved all the way down to the femoral head. There was nothing that can be done when it comes to tumor resection. Here is the MRI. This patient required significant amount of ketamine infusion, and the idea was how to get that patient off ketamine. Surgical options were entertained, including hemicorporectomy, which the patient was not willing and not able to go through. I'm not going to spend too much time on aggressive surgical management like hemicorporectomy, but there are a multitude of sometimes indication for this type of aggressive surgical management. There are multiple papers that have been described on how to do it. I'm not going to spend too much time on it. I'm just putting some slides. A lot of these are multidisciplinary. The other options for pain control is cordotomies that can be done for these type of cases to try and control the pain, or what we have chosen to do here, which is a cingulotomy. And by doing a cingulotomy, and you can see right here how we ended up doing it, choosing the particular places to create a cingulotomy for pain control. The patient underwent from a IV ketamine to a mild need for some pain medication. So in essence, with cingulotomy, the pain is still there, but the patient is unable to sense the pain. And ultimately, this patient was discharged. So I'm showing you these cases because ultimately we are faced with multitude of cases where similar cases are presented by different tumor biology. Here is a multiple myeloma patient with pathologic L1 fracture, just pain. Here is a patient with metastatic renal cell carcinoma. L1 is mildly broken, just pain. Here is a patient with chondrosarcoma, just pain with a L3. All of these looked similar. It's just that the tumor biology is very different. And as we go around again, what to do, going through all these pathways of how much to do, how much lot to do, and you're looking at all these, you have to think about, what can be and possibly the best option for these patients. There are multitude concerns, right? And you can see right here, these are all self-explanatory for a lot of these patients when it comes to the weight loss, immune status, coagulopathy, consideration of wound complications if these patients have been radiated, unlikely fusion for a lot of these patients. And as you talk about each one of these separately, I'm again not going to spend too much time on it. There are big risks for a lot of these cases when it comes to surgery, when it comes to immunocompromise. Their nutritional status tends to be on the low side, so the wound healing is significant issues. A lot of these patients are on steroids with all the side effects that goes along with it. Some of these patients are coagulopathic up front. A lot of these tumors are vascular, and I'm listing here the vascular tumors and which ones needs to be embolized or not. And ultimately, you want to think about that as you proceed with surgery. Here is a renal met, very vascular post-angiogram. Wound management is serious consideration and importance that you have to pay attention to. Potentially get the plastic surgeons involved. I published this paper with my plastic colleagues when it comes to the fact that a lot of these cases need multidisciplinary with our plastic colleagues. When you're dealing with stuff like this, with sarcomas, big tumor that are eroding through the back of the skin, it's not just about removing the tumor, but also the ability to close these wounds. Here is a patient with chordoma. This is what it looks like at the end. We are not going to close it ourselves. We really need our plastic surgeons to close these wounds. And beyond wound closure, there's just basic other risks, like even vision loss, right? Some of these big, rare complications of vision loss after patients with a significant blood loss, volume loss in these cases. So histological evaluation is very critical. Make sure that you get a biopsy of what it is you're operating on. This is a patient who was sent to me for unblocked resection of presumed chordoma. This is what the lesion is look like. This turns out to be ectopic extramedullary hematopoiesis that does not need surgery. So establishing a diagnosis is very critical. Make sure to avoid the transoral or the transrectal approach to be able to remove the tract with the specimen in order to minimize the tumor contamination. And you can see how I leave the tract itself here, moving the skin around the tract, and here where you leave that area with the skin where the tract was done to be able to get around it and remove the sacrum here in one piece with the tract itself. I will fail to say that obviously you have to think about the primary tumors when you're dealing with metastatic disease because they are completely different animals in many ways. Metastatic disease is really the powerhouse of a lot of what we do because that's the majority of our patients. The recommendation after the Roy Patchell study is really not to just consider radiation, but also to consider surgery in these patients. And when it comes to these surgical approaches, these are the four options that we have: the intralesional, the en bloc, the radiosurgery, or cement injection. Intralesional is really the powerhouse, the, the big surgical tool that we have to treat patients with metastatic disease. Here's a patient with metastatic melanoma with pathologic fracture, bone in the canal that ended up with a vertebrectomy and a reconstruction here. And then you can see what it looks like. This patient ended up getting a recurrence very quickly within 1 month and ended up going through doing this, where we took the tumor from the rest of the front through the back and ended up with something like that. Be ready to do most surgeries on patient there with metastatic disease. Reconstruction is very critical. There's going to be some talks about carbon fiber screws, titanium screws, all options for patients with metastatic disease. Radiosurgery, I'm just going to put some slide, or Dr. Yi, who's my colleague here at Yale, will talk about it in details. But ultimately, stereotactic radiosurgery is extremely powerful tool for our patients with metastatic disease, and I'll let Dr. Yi talk about it. I just want to put a cautionary note here that you always have to consider iatrogenic fractures after this radiosurgery, and there's always some talks about prophylactic cement on some of these patients when it comes to iatrogenic fractures, and these are a few cases that you can see right here with were a great candidate for radiosurgery. Cement, I mentioned briefly, is also one of those tools that we have to be able to do it. There's a lot of pros and cons and some contraindications of when not to do it. I think that's a completely separate talk that we'll have somebody talk about of when not to do it. And some of those things are about severe canal compromise, bone in the canal, erosion of the back wall. Ultimately, you do not want to end up with cement leakage. You can see some bad cement injections, and you can see some of these cases where there's cement everywhere after injections. There's some cases with you can see right here pleural mets, not mets, pleural cement particles, brain particles. So you have to be careful with the vertebroplasty procedure. Sometimes the contraindication is severe. It is a case with severe cord compression, severe pathologic fracture. I ended up doing cement on this with complete relief of pain. Again, you got to be very careful of who you're going to do it on and how much you're going to push the limits. There was a patient with a C2 pathologic fracture from a renal met who ended up getting a transoral cement injection, and again, pushing the limits on these. This is a case that Dr. Katsir and I have published when it comes to doing some of these transoral cement injection for these odontoid pathologic fractures to take away the need for an occipital cervical fixations. I published on proposed contraindications of these procedures, but ultimately the conclusion was that you can really push the limits and not put patients who are in significant amount of pain helpless. The en bloc resections, again, the primary tumors, I'm going to leave some of those cases for the primary bone tumors. Spinal instability, you all know about the SIN score. I'm going to let some other guys talk about this. That's also a huge tool for us to be able to use when it comes to a need potentially to proceed with surgery for these patients. And this is a very beautiful table that you can add the numbers and decide whether patients need surgery for spinal instability. Neurological compromise many times ended up with surgical intervention where you're going in, and that's one of my indications to do surgery. And pain is also an indication to surgery, especially the mechanical back pain symptomatology. All I want to say is that when you plan surgery, be careful. make sure it's durable, patients benefit. There's going to hopefully satisfactory postoperative function with acceptable mortality. Those cases are those surgical cases. You have to be familiar with all kind of surgical approaches. It's not just a laminectomy. Sometimes it requires vertebrectomies to also transpedicular vertebrectomies, like what you see here. Sometimes you can use transsternal approaches, which I've done on occasion, to be able to get and do these vertebrectomies. You have to be familiar with multitude of surgical options. My interest for the future is really 3D printing when it comes to creating personalized models for patients with Mets, and then ability to create smaller construct, if all possible, with 3D printer that are personalized for those patients who undergo this type of surgeries. So in conclusion, the management is challenging. It is very helpful for patients to restore, protect neurological function, improve pain. It can have and does have significant impact on the quality of patients' life. Surgeons who are doing or involved with this needs to be familiar with the various surgical approaches, not just the laminectomy, but you got to be able to be open to and know how to do these approaches, whether it's anterior, posterior, lateral, whatever it takes. Understand that tumor biology is super critical when it comes to the decision making. And remember that ultimately it's in the individualized management scheme, it's multidisciplinary for a lot of these cases. So by that, I'm going to end just kind of general overview for patient there with metastatic disease. So thank you.
Great stuff, Hudi. Thank you so much. I have one big question in this big picture purview of yours, and you emphasized the importance of teamwork. You showed impressive slides, not just of cases, but of your team in action. My simple questions are the following. Who is in charge in real life? And who should be in charge? Because with all those specialties and all those egos and knowledge bases floating around, there should be somebody who kind of directs traffic. So staying the American sports kind of a vernacular, who's the quarterback?
Yes, so you have, I'll tell you from my own experience, building several spine tumor programs, and my most recent one is here at Yale, and that is the spine tumor board in all places that are being run by the surgeons. And I think that is very critical because ultimately I believe that this is our responsibility. We know what we can do, and we know the power that we have in our hands with the surgical intervention. I think that when we present these cases in our multidisciplinary spine tumor boards, it's critical to hear the thought process of my colleagues, and Dr. Yi will talk about this, and my colleague, Dr. Kolb. These are guys I work with daily. It's super critical to hear what they say, but I think ultimately the quarterbacking, my belief, should stay within the surgical aspect, because if things deteriorate, if things don't go well, I believe that ultimately it's our responsibility. And even if we decide ultimately that it is the surgery route to go, and it may be a radiation option and it may be chemotherapy option, we have to put in our surgical opinion. And several times it will have happened that medical oncology would say go for surgery, but they may not necessarily know what surgery means. It can go the other way around, where we say we understand, but this is the type of surgery that's needed here. Is that realistic? So we understand the power of the medical oncologists, the hematologists, and the radiation oncologists, but we know also what does it take to do these surgeries, and potentially what are the risks to do these surgeries. Sometimes the extent of surgery is very critical. When you have non-contiguous multiple Mets and each one of them needs surgical intervention, it makes the decision making very critical. And it's sometimes up to the surgeons to decide which lesions to go after. So to answer with a very long answer to your question, I think ultimately the quarterbacking should stay within the surgeon's arena. It may be controversial, and you have to have colleagues that you work with, and you have to be open to them convincing you sometimes that it's not the right to go the surgical route. Or maybe for them to be open to the fact that they know what the power that you have, but they feel that radiation is the way to go. And I always say to my colleagues, I don't need you to tell me if you cannot do it, this is what we can do. I need to hear what they have to say when it comes to their own opinion about the surgical versus the non-surgical options on these patients.
We're switching to a lab in a second, and we'll have the benefit of hearing from Mickey Katsir shortly. Mickey, I saw you nodding. Do you agree with that model? Are you the boss in Nebraska?
Tough question, but yes, we know.
You're on record. We're all recording you.
Yeah, good. That proof. So we know what we can do, what we can't do, right? The most difficult thing to do in these patients' treatment is the surgery itself. It's always not easier, but it's always doable. We can always deliver radiation, any type of radiation. Any type of radiation. There's always some chemotherapeutic agent. Usually we can administer, but we not always can go to surgery. So eventually the rate limiting factor is us, right? We need to say, first of all, yes or no, or even does he need to, right? If it's a multiple myeloma, we don't even need anything to talk about. There's nothing to talk about. Or a lymphoma, there's nothing to talk about. So we know what we need to do. And so that's why I agree with Dr. Mendel saying that we need to be the quarterbacks at this. But still, tumor board is super important, and we can't take these decisions alone.
So we'll keep this discussion going. Great insights. That was a fabulous presentation. Thank you, Ehud.